Welcome to this session. It is my pleasure to present to you on intimacy and sexuality in cancer. My name is Dr. Ramlachan in South Africa, Durban, and I want to thank the ASCO executive for allowing us the privilege to participate in this program. I brought up the African Society for Sexual Medicine as we now have a special algorithm which I will share with you today regarding psychosocial and sexual care pathway in cancer patients. The psychosocial and sexual care in cancer is very underappreciated, under-recognized, and under-discussed, and is a commonly unaddressed need in cancer care models in Africa and worldwide. Cancer is a biopsychosocial cultural disaster for both the patient and his or partner and family. And we have to look at it in that sense to get to helping and caring for our patients. We know that the reaction to diagnosis of cancer is shock, distress, anxiety, fear and uncertainty, depression, denial. But what happens is, with that comes change. Change both in roles, relationships, communication patterns, intimacy and sexual functioning, which lead to severe stress and lead to distress, which, as you know, is the sixth vital sign that we have to maintain and keep in cancer. Now, the disparities in psychological distress are different in different groups, and we have to be cognizant of LGBT versus heterosexual populations. We ought to look at Black versus white. We've got to look at lower income versus higher income of cancer sufferers. And we have to always look at this in perspective, otherwise our caring model will not care for our patients in the best possible way. The incidence of sexual problems is high, and I want to say that when you start to look at the percentages that suffer from sexual dysfunction, the numbers are really embarrassing in a way to think that we've not looked at it in such high numbers, but quite real when you look at prostate and breast, which are the commonest cancers you see, and then the gynecological cancers of CA cervix in Africa, and also those who are receiving treatment for rectal cancer and other problems in the country. So we need to look at this all the time and realize that sexual health is impacted regardless of the cancer type. And cancer is a we disease. It's never a single disease, because if it's not in a partnership, it is also somebody who's got relationship with family, etc. But we know that emotions, finances, sexuality, all are impacted by cancer once a diagnosis is made. And when the diagnosis of cancer is made, usually sexuality is a low priority. But as the times go by and we heal and go into survivorship, we now realize that sexual health becomes important again. And we need to open up this dialogue, importantly for all of us. And the tragedy is that a lot of our treatment teams do not know how to bring up the topic, because the issues to be dealt with cancer overshadow the needs such as sex, love, and intimacy. We don't have enough sexual health care experts around the country and in Africa and in the world to assist all our patients. So we have to look and come up with solutions that will assist us in this. Majority of patients report reductions in sexual functioning, and that sexual difficulties can be one of the most enduring effects of the cancer diagnosis and treatment. And sex is a concern for patients or individuals, whether it is a sexual cancer or a non-sexual cancer. So please do not think that those who have other cancers like lung cancers don't have sexual difficulties. There are large unmet needs. And the pathway in this process of before and after and during is something that impacts not only sexuality, it also impacts intimacy, it impacts relationships, it impacts finances and psychological changes which one sees. So when you start to look at this pathway of the patient, in the pre-morbid phase, we can see is that as the complaints and worries and the diagnosis start to kick in, when the diagnosis is made and the treatment starts, you can see all of these go to a low. Psychologically, financially, sexually, intimacy, relationships go to a low. And as they repair, they start to come to a more or less back to normal, or what I call a dipping normal. And in that phase, you can get the newbies, where people who've been treated and start to repair and become a new person, or we get the new we, where we get changes in partners, etc., happening in this time. And your sexual load pattern will start to change depending on how they handle the palliative phase as we go along. So those will start to grow bigger in their process, while those might suffer and go into a different phase altogether. We need a multimodal team, and that is one of the recommendations of the African Society for Sexual Medicine, and that is that we need nurses, community health workers, family practitioners, social workers, psychologists, community-based sex therapists, oncologists, gynecologists, physiotherapists, urologists, fertility specialists, physicians, surgeons, and nutritional specialists. We need nutritional specialists in this process and non-governmental organizations. The pathway that we've looked at is that if we look at the cancer care pathway in patients, if you suspect cancer and we start the investigation, look at the identifying variables for that patient, but look at future fertility in the investigation and diagnosis phase, because you need to save fertility before you even start certain procedures for investigation, which might harm the fertility processes in the person. Once you start management, we ask everyone to look at psychosocial and sexual difficulties, and in the trajectory of illness is to say, let's look at all of that together, because we'll have the disease progression and treatment, the survivorship process, and then the palliative and end-of-life care. So bring it all together, we're saying sexual issues and psychosocial issues are a major problem during the management and trajectory of illness of patient, and we need to address those as we go along in every patient and family, so we give them complete care. When would the discussion occur? The discussion should occur as soon as possible, or as soon as people are comfortable, so that psychosocial and sexual health are discussed with the patient. Fertility issues must be discussed early, because if we don't, we're going to lose fertile tissue, which we don't save, will be lost in radiation fields, treatments, gender processes, etc., and we need to get that correct. We know that cancer treatments affect sexuality and fertility, and all of them are listed here, both from chemotherapy to lymph node dissection to radical prostatectomies, and you can see they affect desire, erection, orgasm, dry orgasm, weak orgasm, infertility, and so the list goes on. And we need to make sure that we address this with the patients before we even start to push them into the treatment phase, so that they understand that they will have a few issues which we can assist them with. And you'll find that once they start to drift into the caring of survivorship, they actually start to bring this up and say, Doc, what about my sex life? In the investigation and diagnosis, we need to make sure that we look at the future fertility for men, and in future fertility in men, we need to take semen analysis, ejaculate storage, biopsies of the testes, and also look at the reproduction before we start chemotherapy and radiation. In women, we need to store ovarian tissue and ovarian follicles. Embryos and oocytes are still in experimental stage, but in our young children, before we give them chemotherapy, we need to see whether we can store some embryo oocytes for future use and make that happen as we go along. And all the identifying variables as the age of diagnosis local condition resources are important. So re-establishing a new sexual balance, routine, and habit for most couples with cancer is a serious challenge. And that is why we're saying when it comes to sexual issues, the 7 listed sexual issues were the ones recognized as most important in patients with cancer: the sexual response, the body image, intimacy and relationships, altered sexual function and satisfaction, vasomotor symptoms, and genital symptoms. And this is for both men and women, and then specifically erectile or ejaculate dysfunction and absence of ejaculate in men are the things we need to address. So if one needs to keep this imprinted in your mind and try to realize which treatments, which therapies, which surgery will impact the patient in a different way as regards these issues, you can easily start to share with the patient a caring pathway to help them with their sexual and intimacy issues. And we know that the difficulties following cancer due to sexuality are usually the results of effects of the cancer treatment rather than the disease itself. And we have to look at the meaning of sex, the sexual experience, the importance of sex, the sexual satisfaction for these patients so that they understand where they are, so that they can function sexually and really have a good, full life. Once cancer is diagnosed and the patient is in a treatment pathway or management pathway, we notice that sex follows different patterns. 1, they quit sex completely. 2, they only have sensuous intimacy, and sensuous intimacy is a great, great, great stimulus for relationship building and for keeping it all together. There's not a single couple who say that ever since we've stopped touching and being intimate, we've lost the contact between us, and that's important. Continue as usual because nothing has changed, or we're back to our old intensifying of sex to make it so much better, or the desperate, aggressive sex. And I put in etc. to say that due to all of these above, you start to develop new patterns of how you will take your sex into the palliative phase if needed, and how sex can be most gratifying in that palliative final phase of life. When you look at any sexual dysfunction or problem, it's always important to realize that the psychology, the socio-cultural, the biology, and the interpersonal always come together to impact sexuality. And therefore, when you're looking at the patient, please remember to see which part of him is most affected and give him supporting care in that region, whether it's performance anxiety, whether it's a physical health problem because of chemotherapeutics or radiation therapy or poor nutrition. What are the cultural norms and expectations? Like in Africa, lots of patients become part of a bewitched process when they have cancer and therefore are not allowed to function properly in that environment. And then relationships. Relationship, relationship, relationship. That is the cornerstone of good sexual care. The multifactor model by Perelman is a wonderful model, and I like it because the sexual tipping point process brings out this whole balance between inhibition and excitation. And that inhibition and excitation model is what we need to look at to balance the physiological, the organic, the psychosocial, the cultural, and behavioral issues. And what do we want to do in all of this is in our patients bring up the excitation that will give sex its true value in their relationship once cancer is in their lives. The sexual response, as you know, includes desire and arousal, alternate sensation in orgasm and anorgasmia for both sexes, In men, it also includes erectile dysfunction and absence of ejaculate. And if I bring this into a larger picture and you start to look at the different phases of the sexual response, you suddenly see that in the desire phase, when you get damage to the endocrine system by chemo, radio, castration, hormonal therapy, you know that your patient's going to have difficulties with the desire part of the sexual response. We know that surgery, radiotherapy, and just growing old will affect the circulation, and therefore excitement and arousal will be there with concomitant illnesses sitting there like diabetes. And then the orgasmic part can be interfered by the nerves and neurotransmitters, surgery being a major player here. And as you know, that we see that a lot in cancer of the prostate and other surgeries, and in the brain, and also the use of the SSRIs and SNRIs in our treatment of patients, because depression also accompanies the process. So looking at female cancer, we know that the commonest is breast cancer. Sitting close by in Africa, cervical cancer. In fact, in some countries, cervical cancer a little bit more than breast cancer. But we know that when you look around you, the chemotherapy and the endocrine therapy with chemical-induced menopause and breast cancer surgery results in a range of changes to women's sexuality. Sexual function, sexual arousal, lubrication, orgasm, sexual desire, and sexual pleasure. And it's up to us to look at each phase and try to address them, because when you start to look at the treatment consequences, you see that when you have surgery, identity is lost, and there's a general loss of an erogenic zone, and that loss of that erogenic zone is what's giving the patient this poor feeling. And so with the chemotherapy, one can have a loss of identity and desire, orgasm. Tamoxifen always interferes with the dry vagina and lubrication, and changes in the ovaries and the use of aromatase inhibitors giving us this bite. Gynecological cancer, as you know, in Africa, we have numerous cases of cervical cancer and vaginal atrophy, decreased lubrication, fibrosis, narrowing of the introitus. All are there as part of what we need to look at, and how the intimacy can be restored by having the sexual dysfunction addressed. And as you know, use of non-hormonal lubricants, vaginal dilators, etc., assists us greatly in this area of gynecological cancer in women, together with the multimodal team working on the process. Prostate cancer, is it a problem or is it a dysfunction? And we always need to know that, because the dysfunction is it doesn't function, whereas a problem, it bothers me. They both should be together for you to have a sexual dysfunction. Wait and see, the best, because you actually don't interfere too much with sexual difficulties. Brachy and external beam radiotherapy are going to give you all a host of erectile problems. Radical prostatectomy giving you ejaculatory problems and erectile problems. Nerve-sparing operations saving the erection a little bit, whereas your ejaculation problems would be quite severe because it's still a prostatectomy. And desire changing because of the use of external medications. Androgen deprivation therapy giving you 100% desire problem with a little bit of erectile problem, but ejaculation problems can also be high. Orgasmic problems can be related to that. So it's important for us to have this in mind before we even go in the patient, to give them an idea as what could happen and how we can assist them. Remember that when there's an erectile problem, there's a man connected to that penis. And therefore, every man is also connected to a partner, and we need to look at the partner in this process. Body image has always been afflicted and affected by cancer and its treatment. And therefore, it's so important for us to look at this, because once there is body image disturbance, you can get either one of two scenarios. I'm proud and exhibit my beauty, or I am sad and depressed and anxious and I have a loss of femininity. And these body image issues were associated with a higher rate of sexual dysfunction in a lot of patients. Don't forget fecal incontinence. Don't forget ostomies, alopecia, mastectomies, change in perineal and testicular size, because they all impact the body image when it comes to sexual issues. Intimacy and relationship issues will always give our cancer patients difficulty unless we are there to support them. And as you know, in the studies done, it showed that women perceiving high support, cancer-related intrusive had no significant relationship to quality of life. But with those with low levels of perceived support, the relationship between cancer-related intrusive thoughts and quality of life was significant and negative. So it's important that support for intimacy and relationship is always there. And increasing closeness, greater intimacy, congruent views will always lead to a good outcome versus increasing conflict, breakdown, and incongruent views. And self-silencing or the protective buffering you see in the partner to prevent distress and to achieve intimacy sometimes leads to a lot of inhibition of self-expression in caretaking and relationship building. And therefore, the partner roles become important because now a partner is becoming a caregiver and a sexual partner, and that becomes difficult for patients to have that conflict in their own needs and satisfying the roles of what they have for the patients. Vasomotor symptoms are common both in men and women, and therefore there are treatment patterns. One can use gabapentin, venlafaxine, or SSRIs. As you know, you can't play with the hormones here. You can start to use your adjunct therapy to assist patients who have vasomotor symptoms. Genital symptoms post-surgery, as you can see, we need to make sure that we have to help the patients with pelvic pain, vaginal dryness, and vaginal stenosis, and with men who get radiation to that pelvic area suffer a lot of discomfort, both from the erectile dysfunction, the fibrosis of the nerves that occur, and give them difficulties. We have lots and lots of systems and processes which our physiotherapists and together with our sex therapists can bring to patients with genital pain, lack of lubrication, speaking to partners, comfortable positions, vaginal dilators, vibrators, lubrication, vaginal moisturizers, all assist in giving our patients that return to sexuality in the comfort of no pain. And that is so, so important for them. And we know that sex can relax emotionally, console and comfort, relax physically, distract from pain, reduce pain, improve the human self-esteem, and improve the male self-esteem and female self-esteem. And these are the quality of life topics that need to be addressed when we look at our patients in their intimacy and sexual issues in cancer. So what do we evaluate? The couple, their style, their communication style, their relationship style, how they're coping with the illness, what was the intimacy and sexuality before and after the cancer treatment, and what is their coping style for God. Relationship variables always impact. In all patients, the relationship variables will always be there, and one always has to look for them for the conflict, the incompatibility, the lack of intimacy or trust, because you know that relationships are built on love, trust, and respect. And that is what we need to grow, that tripod of energy into those three: love, trust, and respect. So the first step is a little bit of psychoeducation into providing clear, understandable information about the association between cancer and relationships and cancer and sexuality. Providing information on all the remedies and therapies available for sexual dysfunction, and contributing the feeling of being normal, or what we call the new normal. And the balance method is something that is so good in the sense where you start to balance the inhibitory and the stimulating factors. And once you start to get more stimulating factors in, you start to create a beautiful new process for men, women, men and men, etc., to become sexual and restore the intimacy and sexuality in their lives. And once you've made this balanced method, we want to ask the couple to start to make a list of the inhibitory factors and discuss it. So I don't like this, I like that, and therefore you start to create these inhibitory factors and your stimulatory factors, so that once you address them, you challenge the couple to believe that the situation is changeable and whether they would like to change it or not. And once they do that, they introduce a discussion of the stimulating factors, which the couple is challenged to think about possibilities to increase or promote them, so that sexuality becomes a new norm, a new way of expressing caring and intimate relationships. So always remember that we have to disband a few or dispel a few myths, as this might be necessary for us to get the couple onto the right process and make some preparations before being able to have sex, and therefore putting it forward that it's a shared responsibility and not just one of the processes. Keeping sex life going despite cancer treatment, the patient must still be able to feel pleasure from intimacy, and boosting the self-esteem and communication is the way you'll wake the open mind, and the open mind is what will give you the best sexual pleasure. Sexual tasks and homework, erotic reading assignments, self-stimulating exercise, relaxation techniques, sensate focus, that beautiful teaching of creating that warmth and the sensation that comes from sensate focus brings a new utopia to people, so that there's a change in the role of partner from intimate companion to caregiver is overcome, and therefore they can enjoy physical intimacy, emotional intimacy, sensual and erotic contact, and sexual and genital play and contact. So in this integrative process, we need a few team members or team players, part of the multimodal team, to give patients cognitive behavioral therapy, mindful sex therapy, couples intervention, psychodynamic intervention, and hypnotherapy. And mindfulness is a beautiful tool. If you are in the moment, that is where you need to be. And the cooperative word, and which operates, is the word nowhere. If you take nowhere and separate the W and H, you now get now here. So you're now here in the moment, and understand that mindfulness takes you to that now here moment. And with mindfulness, you get this beautiful control that women and men can have over their brains and so their body in sex. Education, education, education always helps all our patients to communicate the best they can have about sex. And we have many solutions. The solutions are there, whether it is the PDE5 inhibitor drugs, whether it is the intracavernosa injections, whether it is the stimulators, the vibrators, the lubricants, the moisturizers, all of them will give us solutions for our patients, so we assist them to get better, right down to also sending them, if they have problems, to have some shockwave therapy to the penis to assist in erectile dysfunction. If not, then we can also put in for them implants, which will give them erection. But the toys are there, and the toys are recommended so that we have extra lubrication for sensation, teaching orgasmic sills with the vibrator, looking at how we use the clitoris stimulated device to overcome hypoactive sexual desire disorder, arousal disorder, orgasmic disorder, and looking how we use dilators and small vibrators in assisting in vaginismus or vaginal sensitivity. And when we look at female sexual arousal disorder and hypoactive sexual desire disorder, as you know, that's now combined into the female interest arousal disorder. We know the psychotherapeutic interventions will help us. We know we can use some hormones depending on whether we have hormone-dependent cancer or not, and we can use our antidepressants, which help us greatly. Herbal agents and lubricants also help. For female orgasmic disorder, we can use combination therapies of directed masturbation, sensate focus, sex education, anxiety reduction techniques, cognitive behavioral therapy, mindfulness, and coital alignment, a wonderful process to teach couples how to get orgasmic using coital alignment in the process. Hormone treatment when you can and is allowed under direction from the oncologist. And when we deal with patients with sexual problems, we know that sexual counsel should be routinely provided, provide information, open sexual communication, and we know that the changes in sexual function occurring after cancer treatment may disrupt the sexual relationship and may require adaptation to the new situation. For men, the algorithm for erectile dysfunction is there for all of us to use, and whether it is a hormonal cause or a psychogenic cause or an organic cause, we must make sure that we exclude cardiovascular risk factors and then start the patient on PDE5 inhibitors, and those who fail, we use either vacuum or we use the intracavernosal injection. Chemotherapy affects erections, and we need to keep that in mind, so we need to look at that. They also affect infertility and fertility, so we need to keep that in mind also. And anejaculation is a big problem after prostate cancer surgery, and therefore we need to help our patients by giving them a vibrator which assists in ejaculation, or if they need fertility, is for us to try to get sperm and then get them onto the process. So the dry orgasm or the retrograde ejaculation must be looked at. Don't forget the climacturia, which is a passage of urine during sexual intercourse, and that's important to tell patients and overcome it by using a band over the penis so it compresses the urethra and we don't get leakage of urine. So these are the simple things to teach patients. Avoiding stool or urine before sex prevents accidents which are really embarrassing. And we need to assess this in the 5A framework. Ask about sexual health, advise that help is available, assess the problem, assist and direct patients to what is needed, and arrange follow-up. And now with the easy access of all patients to the process of internet-based or web-based services, we can reach our patients in the most rural areas and even give them care from all our different members of the multimodal team. So in finishing, I want to say that in our model for the ASSM, we're looking at the trajectory of illness and how that comes across and how we should care for patients in that, looking at how the disease progression will end up affecting survivorship, legal and financial issues, how survivorship will bring about the concerns about sexuality and fertility, employment, family processes, and how we need to care for our patients at the end of life care. How do we look at sexuality in end of life care? How we look at all the other emotional, financial, caregiver processes and grieving that needs to come with palliation and end of life care. And also I present to you the ASSM care pathway model for patients with psychological, psychosocial, and sexual issues, and how we need to look for them in our cancer patients worldwide. In bringing them all together, the quote, Addressing Female Sexual Function After Cancer from the JSM, the Journal of Sexual Medicine, is that physical pleasure and emotional intimacy are life-affirming experiences that can relieve stress and promote closeness and healing for both survivors and partners. So if we keep this going of optimizing sexual function, we can really take our patients to another level. So staying connected, simple tools to bring intimacy back, hugging till relaxed, heads on pillows and gazing into each other's eyes, which you might not have done for ages. So please practice that whether you have cancer or not. Feeling while touching to get your partner experiencing the beautiful feeling and touching that has to be expressed in an intimate relationship. Kiss deeply, but please watch out for COVID. So those of you who are watching out for COVID, but kissing deeply is the key, because we never know whether we will see our loved one again or our partner again. Change attitude towards sex and fall in love again. Focus on being sensual before being sexual. Make spending quality time together and romance a priority. Spend time touching outside of sex. Women need affirmation about their bodies. Men also have their insecurities. Just don't say no to having sex. Maintain the insecurity. It keeps romantic fire, passion, sexual attraction tingling, and spice things up. So the homework for all of us and for our patients with cancer is refocus sexual energy and feelings, become assertive, have sensual assignments, practice them, schedule time for romantic settings, have an affair with your spouse, not your neighbor, alternate initiating and regular sexual activity. I call on all of you to join, and if you're from Africa or around the world, to join the African Society for Sexual Medicine at www.assmweb.org to register and be part of the ASSM. Thank you very much, and it's been my pleasure to talk to all of you from South Africa in the lovely city of Durban with its beautiful warm weather and beaches. Thank you very much to the organizing committee. Thank you.